So many people are looking to live happier, more stress-free lives. We provide interviews from mental health experts across various fields because we know finding quality information isn't always easy. Let's find more sanity together. Hello and welcome back, everybody, to Sanity Podcast. We have a very special guest who agreed to come back on the show, and I'm very thankful, Dr. Jonathan Abramowitz. I'll do a quick introduction because he is a second time on the show, but just a reminder, he is a clinical psychologist, is a professor of psychology and psychiatry, and director of the Anxiety and Stress Disorder Clinic at the University of North Carolina. He is an internationally recognized expert on OCD and anxiety, has published over 300 research articles, books, and book chapters, is past president of the Association for Behavioral Cognitive Therapies, past editor of the Journal of Obsessive Compulsive and Related Disorders, and of course is a regular presenter at conferences, which I just went to your talks a month ago, and I already started using some of your scales in my private work, and has received numerous awards for his contributions to the field and numerous NIMH research grants. John, welcome back to the show.
Thanks, Jason. Thanks for having me back. It's a pleasure.
So for frequent flyers, we know that John came on to talk about the inhibitory learning model of exposure. I was just telling him that he has jumped quickly to one of my top episodes, competing with episodes that have been around for like 2 years. It's an amazing episode. Make sure that you go back and listen to it if you want to learn about anxiety treatment and exposure. It's just a great piece of work on his part.
Thank you. I'm honored. I am flattered. All those things.
Yeah, look, you're podcast famous now.
I'm podcast famous. Yeah. Thanks.
Okay. So today's episode, we're going to be talking about the DSM. And so I'm just going to launch you a really broad question just to start with. How's the DSM doing?
How does the DSM do it?
No, how are they doing?
Oh, how are they doing?
Yeah.
Yeah, they're not doing very well. So just to kind of back up just a little bit so that for listeners who might not be, I'm looking at a picture of a book here. For listeners who might not be familiar, the DSM is really, it's called the Diagnostic and Statistical Manual of Mental Disorders. And this is the Bible. So every mental health professional has to have a copy of this on their bookshelf. It is the book that outlines the diagnostic criteria for all of the, psychiatric disorders, obsessive compulsive disorder. Here are the criteria. You have to have these kinds of thoughts and these these kinds of behaviors and this impairment in functioning and all these kinds of things. And so all the disorders are laid out here. The book has like 500 and some pages, hundreds and hundreds of diagnoses. And it's published by the American Psychiatric Association. And the aim and the book's got a number of different aims. One important aim is that it codifies these different problems, maybe for research purposes. So we can study people with depression. We can find people who, all line up with these diagnostic criteria. And we say that they have a problem called depression, whatever that is, or OCD or bipolar disorder. It also has these numbers that we use as clinicians when our patients need to get reimbursed for insurance purposes. So the insurance companies are on board with the DSM. And so we take that number and we put that in the insurance claim, and the insurance says, oh, you have, this psychiatric disease, so we will reimburse you for getting services. And then, it's also a way for people to kind of think about how are these disorders, how is one different from the next? How is each one different from the next? And it's a way of kind of grouping the disorders into categories. So you have the anxiety disorders, and there's 7 or 8 that fit into that category. You have the mood disorders. Yeah, there's 7 or 8 that fit into that category. And so it's it's American psychiatry's way of kind of saying, here's our nomenclature. Here's the way that we're grouping these disorders together. Here's the way that we're defining the boundaries between one disorder and the next. Mm-hmm. And the book is now in its, so technically we're in DSM-5 text revision, DSM-5 TR. And the DSM started, DSM-1, they didn't call it DSM-1, it was DSM in 1952. And it was just a small little spiral bound book. If you look up images of DSM on Google, you'll see the first DSM was a small little, I think it was gray, little spiral bound book, handful of pages. It didn't have very many, disorders listed in it. I think it was like 128 different disorders listed in it. And then DSM-2 came out in 1968. And then in 1980, we have the first of kind of what we call the modern DSMs. It looks a lot like it does today, a much larger book. And just to kind of put that into context, in 1980, we have 265 diagnoses in the book. And then in 1987, we had DSM-3 revised, DSM-3R. In 1994, DSM-4. In 2000, we had DSM-4 text revision. In 2013, we have the DSM-5. And then just recently came the DSM-5 text revision. So every decade or so, they're coming out with a new book. And again, this is the Bible of mental health. Everyone needs to have a copy of this. I actually don't have a hard copy because through my library at the University of North Carolina, I can get access to it. So let me just stop there and see if you have any questions or things that you want me to address, because there are some positives to the DSM, but there are also a number of limitations.
Mm-hmm. Yeah, and I just want to reiterate the purpose of this here. So every clinician in training is learning about the different diagnoses and how we actually diagnose them based on the DSM. And in there, it will say like depression has been depressed more days than not for 2 weeks, and then we'll have symptoms underneath it of depression. Poor mood and things like that. And so there's actually symptoms listed and there's criteria. And then we say, if you meet the criteria, if you're being very strict, you have the disorder. And if you don't meet the criteria, then you don't have the disorder. And when people are coming to treatment and someone is diagnosed with generalized anxiety disorder or OCD, it is really supposed to be based on this DSM. So if you're a client and you never heard of these letters before and you have a diagnosis, it's really coming from this book, and it really informs the entire mental health field of currently how we're classifying disorders, rightfully or wrongfully, or having problems or whatever, but it is the current state of affairs and how the field as a whole is thinking about it. But to your point, people do have things that they're doing some great things and also things that they're not doing so great on. So on your side of what you're thinking, John, what are they doing well and what are they doing not so well?
Yeah. So I think a benefit of the DSM, as I mentioned before, is that it helps us with conducting research up to a point. And I won't get into all the nitty gritty, but, if we're going to learn about, people's difficulties, we might as well have a way to kind of to group them together, so that if we want to do a study, I study OCD. So if we want to study obsessive compulsive disorder, we have people that in the group of folks that we're studying that generally tend to resemble each other. And so these criteria are fairly helpful, not entirely, but they're fairly helpful in establishing, groups of people together who we're going to study, and we're going to say that they have the same problem. And we can develop treatments that broadly might work for that same problem and theories that broadly might be applicable, to that same problem. And I think that is one thing that the DSM has helped us with. There are people who would argue against that, but for my money, I think that is a strength of the DSM. One of the limitations of the DSM, though, is that we have all these different theories and models in mental health. There's the biological model, right? That the mental illness is a brain disease. There's the cognitive behavioral model, that it's your thinking patterns that lead to certain disorders. Right. There's the psychodynamic model that maybe your ego and your id and these kinds of conflicts, intrapsychic conflicts lead to these problems. One of the problems with the DSM is that the DSM does not take a theoretical position. So the criteria are all just very topographical. They're descriptions. And I'm going to read you the description for a very common one, which is social phobia, social anxiety disorder, right? So the DSM-5 criteria for social anxiety disorder say it's a marked and persistent fear of one or more social or performance situations in which the person is exposed to unfamiliar people or to possible scrutiny by others. The individual fears that he or she will act in a way or show anxiety symptoms that will be humiliating or embarrassing. Now, that's one criteria. There are 5. The second criteria is that exposure to the feared social situation almost invariably provokes anxiety, which may take the form of a situationally bound panic attack. The third criteria is that the person recognizes that the fear is excessive or unreasonable. The fourth criteria is that the feared social or performance situation is avoided or else endured with intense anxiety. And the fifth one is that the avoidance or anxious anticipation or distress gets in the way of the person's functioning, basically, or provides marked distress. And so what you've got, if you read it, is you've got 5 different criteria that, that the person has to meet. But actually, if we look carefully at these criteria, it's really only 2 criteria. Because if you were listening carefully, criteria A, B, and D, are all basically restating the same thing, that you have a fear of social situations and that you have a panic attack or you avoid, right? Those are all things that go along with fear. They're all saying the same thing in different ways. And then E is, and it gets in the way of your functioning. Mm-hmm. So this is true for many disorders. Social phobia is one of them. If you look at the criteria for attention deficit hyperactivity disorder, you'll see things like one criteria is that the person has trouble paying attention. Another criteria is that the person has trouble staying in their seat. Another criteria is that the person's mind wanders. Another one is that they have trouble inhibiting their behavior. But that's all kind of saying the same thing. So don't take my word for it. Go and look, at some of these different the criteria. You can find them online for these different disorders. A lot of them are simply restating the same thing, that you could just kind of ask the person in one question. Tell me what's wrong. Well, I'm afraid of social situations. So one of the problems with the DSM is that it's trying to be like a medical model. You have to have this, you have to have that, you have to have the other thing. But what really is going on is that we can ask people a simple question and arrive at the same answer that, this codified book that costs a lot of money, that the APA, American Psychiatric Association, makes a lot of money off of. We could simply ask questions to arrive at these problems and not have to have it, in these criteria bound sorts of, disorders. Mm-hmm. And that's one of the concerns that people raise about the DSM is that, it looks as if these are medical conditions where you have to have all these criteria. But, again, there's not really, it's not something, if a person meets one criteria, they're usually going to meet all the criteria. And what that gets us to is a problem with the validity of these diagnoses. And when I say validity, what I'm talking about is how do these things actually exist in nature? Do these disorders, is there something about them that is different? Are they different from one another? And are they different from just kind of general experiences that people have? And there are many people that argue that the DSM tries to manufacture these mental illnesses from things that are basically problems with living. So, and I have an example, I guess, that I wanted to talk about when it comes to that.
Oh, yeah. I mean, while you're on it, you might as well go through it now, and then I have some questions for you.
Okay, sure. Yeah. So, one of the problems, again, with the validity of the DSM is that it ignores the social context, and it assumes that the context is the same for everyone. So let's go back to social anxiety, right? Mm-hmm. And we can look in this book and say, oh, if you meet these criteria, you have social anxiety. But let's suppose the person, the person who's experiencing this, maybe they're afraid of social situations, but maybe, who decides if it's a marked or persistent fear? Maybe to them, it's not really getting in the way, but maybe they're the parent, right? Or a partner or spouse or a friend is saying, oh, yeah, you've got a problem. This is getting in the way, but the person doesn't see it as a problem. Who makes that call? And then to even go further, let's suppose you go to a clinician and you say, I think I have social phobia. And so the clinician asks you, these questions, and how much of a problem is it? And even different clinicians will have different perspectives on whether this is a marked or persistent fear, whether the fear is really interfering with functioning. If I say to you, I'm really afraid, like no one can measure that except for me. How does a clinician know how fearful I am as compared to the next person? And so you have the clinician trying to make the call about whether a person's experience meets the criteria for this very subjective call of, is it enough fear to warrant social anxiety? So I could go to 3 different, psychologists and explain my problems. And depending on, their own socialization, they could say, oh yeah, you've got social anxiety. You shouldn't be afraid at all of social situations. And someone else might say, oh, that's not really so bad. It's normal to have, that kind of a fear. Who's right and who's wrong? And I guess what this gets to is that there is no objective test for any of the disorders in the DSM. It is all based on the client's report and the clinician's interpretation. And let me say that again. There is no biological test for any of the DSM disorders. You cannot take saliva, blood, brain images, genetics, and do a workup and say, oh, based on these biological conditions, this person has social phobia. This person has OCD. Even things like bipolar and schizophrenia, we don't have a biological test for. And again, so I think that calls into question the validity of these problems. How do we know when a person really has the disorder versus not? And to that extent, how do we really know that these conditions are real? How do we know that they are not different from just kind of the normal experience that people have? And that's not to poo-poo the experiences that people are going through who have, mental illness. These are serious. There is something wrong. Their experience is not, is not normal, so to speak. It's not what they want. It's getting in the way of their functioning. But does that mean that they have an actual illness in the way that the DSM wants to codify it? We don't actually have that data. So let me stop there and see. I said a lot right there. Let me stop there and see if you have any thoughts about that.
Well, yeah, and how much is that an issue with the DSM, or more so the field as a whole? Because we aren't measuring something like biological or temperature, where we at least maybe in 100 years from now, this might be very outdated. But right now, as a field, there's no hard way of measuring these things. So is it a DSM problem, or is it just we're doing the best that we can?
Well, I think that the DSM is attempting to say that these psychiatric conditions are on par, are the same as a medical condition like diabetes.
I see. Right.
Or heart disease, which we have, or COVID. COVID's a great example, right? We have a test for COVID. We can take a test. I just took one, a month ago. We can took a bunch of them. You can take a test and you can see, does that little line show up? Right? That's because COVID is brought to you by a specific type of virus. But it's not that way for mental illnesses. It's not that way for these psychiatric disorders. There's no spirochete. There's no virus. There's nothing. And in fact, for DSM-5, the American Psychiatric Association spent, I don't know how many millions or billions of dollars and a decade trying to figure out how can we make the DSM-5 based on biology, so that instead of anxiety disorders, we have fear circuitry disorders.
Interesting. I didn't know that.
Oh yeah. And I met with members on the DSM committee during the early 2000s as they were working this out. And none of that came to pass. And in 2013, when the DSM-5 came out, it looked exactly like the DSM-4. And they basically said, you know what? We don't have the data to make this biological because There's not biology. And the people who were in charge of the National Institute of Mental Health that funds a lot of these kinds of studies have basically said, you know what? We were looking for something that doesn't appear to be there. We didn't find anything. We spent a lot of money, but we didn't find anything.
So it sounds
which is disheartening.
So the issue is a bit more with conviction, meaning that they're trying to be as confident in these diagnoses as you would say getting a positive COVID test, where like let's say it's a high like the why am I forgetting the blood test that is pretty spot on compared to the nasal test, right? So that one is pretty yes, no, you have it, you don't have it for the most part, even though there is a small error rate. So they're trying to have a high confidence for something that we just don't have the ability to necessarily have as high of a confidence of saying yes, no on.
Yeah, exactly. Yeah. Let's take substance use, right? Which is one of the most commonly diagnosed DSM disorders. Imagine, let's say, like a fashion model who's using amphetamines each day so she can burn off enough calories to suppress her appetite to the point where she can stay as slim as the modeling agency, requires her to stay. Is that a substance use disorder? Does she meet criteria for a DSM disorder? Well, and I debate this with my classes all the time. And half of the class will say, yes, that's a disorder. She's using amphetamines, right? And half the class will say, but she needs to do it to be able to keep her job. Well, who's right and who's wrong? Where's the disorder? That it becomes subjective. It's in the eye of the beholder. It's in the eye of the clinician. And you better believe that some clinicians are going to say, you know what? I get it. That's okay. You don't have a disorder. And other clinicians are going to say, yes, you're using amphetamines. You have a disorder.
I remember an example. I was on internship at Patton State Hospital in California. And I remember a supervisor talking about somebody who she felt was antisocial, manipulating people, this, that, and the other. And I'm a native New Yorker. And I heard some of the behaviors and I was like, well, actually, I don't like, we had a very different criteria of what like manipulative, like antisocial behavior was, because New York is just a different place than the suburbs of whatever it is. And that really, I think that really struck me at the time as a trainee about this different, how our biases could really change what we consider pathological or not. Like he didn't want to make his bed, so he was paying somebody else with canteen stuff to make his bed for him, which someone labeled as manipulative. And I saw it, well, he's just paying someone to do something he doesn't want to do.
Love it. Perfect example. I worked once with a police officer who had recently, before I saw him, had arrested some gang members. And he came into the session one day and he had noticed a strange car near his home. And he was convinced that he was being stalked by, members of a gang that were out for revenge, right? Mm-hmm. Is that paranoia? Is that real? Right? It depends on who you're talking to.
Yep. It's not paranoia if it's true.
That's right. Yeah, exactly.
Right. And when I used to do forensics, that was our phrase all the time. It's not paranoid if you think it's true. It might not be part of a delusion system. Somebody might really be out to get this guy. Yeah,
that's right. But who knows, right? So would that person meet criteria for delusional disorder or not? That's a judgment call.
Yeah. But whether we're assuming it's reality based or not, based on the information that we have from usually a conversation that we're having with somebody. Yeah. And I'm thinking of another example of this. My social anxiety is relatively low. And people have met me could attest to this. Karaokeing for me in front of an audience, I love it. I love to perform and to do it. And so me, it's very normal to do that. But a lot of people would be very anxious singing in front of a group of strangers, right?
Oh, yeah.
And that would be pretty normative. But if you think about the different groups of there, if you have someone that's like that was in theater club when they were in high school, or they're Broadway people or whatever it is, singing karaoke, and someone not being able to do that, they might see that as being overly anxious, where other people that don't necessarily perform would think that that's rather normal. And based on the therapist that you have sitting in front of you, right? Where we're anchored from, and anchoring is a psychological bias, and maybe we could define that and explain that. But I think that's relative here, because my anchor, which I know and I have to cognitively process and push back on, is singing in front of people in the middle of Manhattan is like, that's no big deal. What's the difference? But for most people, that's hard.
Yep. Absolutely. And I think, that it extends, I think, also to issues of race and gender. We know that
Yes.
depending on your race, depending on your gender, you're more likely to be diagnosed with certain disorders more than others. So again, all sorts of biases. And I think that's one of the big problems with the DSM is because it is not objective, that lots of it is left open to interpretation, which then threatens the validity. I should also mention, which I should have done before, but all these criteria that we have, I read you the ones for social anxiety. Hopefully listeners are going online and looking at other ones. How do they come up? How does the American Psychiatric Association come up with these criteria?
I was literally, that was somewhere that I wanted to go. So please go there.
Yeah. You would hope that it's based on science. It ain't. It's based on politics. It's based on voting. It's based on committees of experts who get together in a room and decide with their own biases that they're bringing to the table, right? What criteria we should have. And well, we don't want to change the criteria for schizophrenia that much because then the number of people with diagnosed with schizophrenia will increase. Oh, but we don't want to decrease the number of people with depression too much because then we won't be able to sell as many antidepressants. There's research showing that a lot of the people who are on the DSM committees who make the criteria, that they have ties to drug companies. You would hope that wouldn't influence that
science,
but it doesn't look good. When DSM-5 was coming out, there was some debate about the diagnosis of depression, and particularly around how long can it be after you have lost a loved one where you meet criteria for major depression. So, and I'm forgetting all the details. I haven't looked at this in a little while, but basically, according to the older DSMs, if you lost a loved one, and which is obviously going to be a very sad thing, you do not meet, and you become depressed. You do not meet the criteria for major depressive disorder unless you've been grieving for, I think it's a year. If you are still very depressed in the context of a loss, inside of a year, you technically don't meet the DSM criteria for depression. Mm-hmm. And what the DSM committee wanted to do for DSM-5 was move that down to 6 months so that you had a lot of people meeting criteria for depression, which is an indication for lots of different antidepressants, whereas complicated bereavement is not an indication for that. They wanted to move that to 6 months. So you only have 6 months to grieve until you technically meet the criteria for major depression. Yeah. And I think in the end, that ended up not coming to pass. They got a lot of feedback saying that was wrong. There was a big article in the New York Times about that. Again, we're talking 10 years ago.
If you pull back to, like, we're talking a lot about the clinician side of it, but, yeah. A lot of people in our society want to try and figure out, what's wrong with me, what's wrong with other people. And they go online and they look at these things. And part of getting a degree in mental health is learning what the tools that we have are. Like, for example, you presented on an OCD inventory with things with like a cutoff score, and above the cutoff score, it suggests that there's a possible diagnosis of OCD. But somebody might take the test and score above it and say, I have OCD, or you have OCD. And part of the training is knowing like what the tools are, how are they useful, what they mean, what they don't mean, how much we can rely on them. Yeah. One issue here is that somebody might read, okay, if it's over a year, now it's a clinical depression. And then they say, well, there's something wrong with you, or there's something wrong with me that I'm still grieving after a year, but it's really based off an arbitrary potential cutoff rather than something. But people not in the know might be making pretty big judgments on that.
Yeah, I think that's a big problem. And DSM also assumes that the problem is within the person instead of being able to look at, society.
Yeah, right? What else are you being discriminated against, and you're having resource insecurity and things like that. Like, do we just say that you're depressed and throw a medication at you?
Exactly.
Or is life not going so well and things are actually really hard?
Yeah. Exactly. And that is, you're hitting on another issue of the DSM, that the DSM assumes that the problem is within the person. And and as you're pointing out, it's not. Another problem with the DSM criteria, and I think I touched on this earlier briefly, is that they're purely descriptive. In other words, they don't give you an indication of the cause of the problem or what the treatment should be. Again, I'll go back to COVID, right? So, and COVID is an abbreviation for SARS, whatever. I forget all the technical name of it. But basically, if you have a diagnosis of COVID versus, let's say some other virus.
Like the flu.
The flu, right. Great example. That tells you about the cause of the symptoms, right? A diagnosis of COVID tells you that there is this specific, type of virus, the COVID virus, and there's an infection based on that, and that's causing these symptoms, as opposed to if you have a diagnosis of the flu or something else, that's telling you it's a different virus that's causing that. And so it gives us some sense of what's the cause, and it gives us a good sense of what do we do next, right? What's the next sort of what's the treatment? In the DSM, the criteria don't have anything to do with cause. So remember, with social phobia, it's just you have a marked fear of social situations and you avoid social situations. And so the analogy that I like to give here is that the DSM is what we call a tautology. It's circular, right? So imagine walking into the doctor's office and you say, "Doctor, I have a sore throat." And the doctor, examines you, maybe, puts his hand on your throat and all this stuff, looks down, say, right? And says, "Oh, you have sore throat disorder," right? Well, okay. Well, doctor, how do you know I have sore throat disorder? Well, because you're telling me that your throat hurts. Okay. Well, doctor, why do I have sore throat disorder? Well, because your throat hurts. Well, why does my throat hurt, doctor? Well, it hurts because you have sore throat disorder. Well, why do I have sore throat disorder? Because you're telling me you have a sore throat. That's a tautology. And that's exactly what we see with these diagnostic criteria for things like social anxiety, things like ADHD, things like, depression. There's no theory, right? Why do I have depression, right? So you have a problem where you have these catastrophic thoughts about yourself and the future and the world, and that leads to depression. We talked before we signed on talking about what would be some alternatives to DSM. And one important alternative would be to look at scientifically supported models of how to understand these problems. And to some extent, maybe biology plays a role. But I think one of the problems that the DSM framers overlook is that there's a lot of, as we've talked about, societal, there's a lot of psychological, experiential, learning, environment, interpersonal influences, completely ignored by the DSM. And so if we were gonna redo this, if we were gonna, just tear it down and start from scratch, we would need to think about, like in medicine, where you have a causal model. The diagnoses are based on causal models, usually, not always, by the way, usually. But we don't have anything like that in DSM.
And one thing I'm thinking is, well, maybe one pro of not having the causal part of it, and maybe this is not the reason to do, but I'm just thinking like paradigm shifts.
Yeah.
Right. So you might have a paradigm as to like, this is why mental, which is say the biological model. Right. And so if that's assumed, and this is our main book, we might be here screaming like, no, that's not right. The CBT way of looking at depression and anxiety, like this is the way.
Yeah.
Right. And so now we get the book to do that. And I mean, I think we're right and I hope we're right, but I'm not above, thinking that 50 years from now, they might laugh at me. I don't know.
That's exactly right.
And so when you do that, will it make it harder for a paradigm shift? But then, that's a pros and cons thing, right? And by paradigm shift, I mean, like the paradigm is the current global way that we are looking at the situation. And like, so say that it was a CBT thing where we wrote the DSM based on the CBT conceptualization of depression and anxiety, it would be a CBT paradigm. But the thing about paradigms is that when it's in there, it's hard to then move away from that paradigm. It's not impossible. We do paradigm shifts, but paradigms like to stay. And it takes a lot of work to shift it. So do you think it's worth, do you think the benefit of actually putting in an etiology is worth the potential dangers of being stuck in a paradigm?
Well, I got a few things to say about that. Number one is that is a great example of the problems with trying to have mental health diagnoses, because the paradigms shift in the way that we think about mental illness. And so even trying to have these disorders where the paradigms might shift in terms of how we're thinking about them, right? Why not have some sort of way of thinking about the problems instead of saying you have this disorder? Let's take social phobia. Why why even worry about that? Why not think about it in terms of the mechanisms and forget about the diagnosis? So I'm a cognitive behavioral therapist too, as you know. So I don't care what we call the problem. I tell my patients, I'll give you a diagnosis for insurance purposes, but the treatments we're going to do, this is not a treatment for social phobia. This is a treatment for these certain cognitions that you have, irrational beliefs about embarrassment and catastrophic thoughts about other people thinking about you, and behaviors of avoidance behavior, right? So why do we even need the diagnoses? We can throw those out if we're going to talk about paradigms and mechanisms and causes and things like that, because the treatments that we have, the treatments that work, are not treatments for disorders. They're treatments for these psychological mechanisms. So I think that's one thing that's important that your point speaks to. Another thing that's important, and you're right, the paradigms change. And if we go back 70 years to the original DSM, I'm going to read you the DSM criteria, the DSM description of a phobic reaction. I think this is from DSM-2. So it's the anxiety of these patients becomes detached from a specific idea, object, or situation in the daily life and is displaced to some symbolic idea or situation in the form of a specific neurotic fear. The commonly observed forms of phobic reaction include fear of syphilis, dirt, closed place. So syphilis, right? We don't worry about that so much anymore. High places, open spaces. But again, you see displacement, right? Symbolic ideas, right? What theory is that coming from? It's coming from psychoanalysis. Mm-hmm. The first two DSMs were influenced by Freudian psychoanalysis. So they actually used to have exactly what you're talking about, Jason. They used to have a theoretical basis. And then in DSM-3, the first of the modern DSMs, they said, nope, we need to remake psychiatry and get away from Freud, which was a good call because Freud ends up being crap. And we need to, but we've got the biological folks, we have the psychological folks, the cognitivists, the behavioralists. We want everyone buying our book, so we're just going to be atheoretical and we're going to appeal to everyone, right? And so they tried to be all things to all people. And I don't think they, counted on it at the time. They weren't thinking completely through, everything that would happen, but they said, we're just going to have these disorders like the sore throat disorder, basically. And that's what happened.
So can you give me an example of a more mechanism-based diagnosis? Like OCD is your jam, right? So if there was like a mechanism-based diagnosis and like we would figure out like that it's OCD symptoms in there, what might that actually look like?
Yeah, if I was going to come up with a better name for OCD, I would say that it is a problem in which a person has intrusive, unwanted thoughts that they misinterpret as significant and threatening, and then they do all sorts of behaviors like avoidance and rituals to try to control or dismiss the thoughts and anxiety, but that doesn't work and backfires. And what I've basically said is a really brief version of a cognitive behavioral model of OCD, which we know from research, there's a lot of support for that. And when I'm working with clients, I'm thinking not in terms of what diagnosis they have. I don't care about that. Let me dial that back. Maybe I care a little bit about it just because, again, people like to have their diagnosis. And we talked about some of the strengths of the DSM. I guess another one is that it helps to make people feel like they're not alone. Oh, a lot of people have this condition, whatever that is, right? And again, I think that there's something to that. We want to help people to feel better. But I don't think in terms of diagnoses. I think in terms of mechanisms, like I just said. So if someone comes to me saying, I have panic attacks, right? In my head, I have panic disorder. In my head, I'm saying, oh, so you misinterpret the signs of physiological arousal in a catastrophic way, and that makes you even more afraid. And so you have more rapid heartbeat and more trouble catching your breath, and you presume that you're dying because of that, right? That is a panic attack. That is panic disorder.
Mm-hmm.
Right.
So is this so much getting rid of the diagnosis, or are you more so saying that, yeah, have the diagnoses, but then base it on the mechanism rather than a symptom list?
I think that we don't need the diagnoses. I think we need to train clinicians to understand the theory better. And instead of going to a cookbook and saying, check, 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 okay, you have social phobia, to understand what social phobia is, right? It's this, and I don't mean it's a tendency to be afraid of social situations. Anyone can tell you that. What it really is in terms of psychological mechanisms, right? Social phobia is the tendency to overestimate threat in a social situation and to view other people as very judgmental and to tell yourself, I can't stand to be embarrassed. That would be like next to dying. And then that's so frightening for me that I avoid. And that avoidance behavior just keeps me afraid. And so the problem just lives on. So I would rather train clinicians in terms of understanding those cognitive behavioral mechanisms rather than the DSM cookbook approach.
Mm-hmm.
Yeah.
But does the DSM prevent you from doing it? Because you train a lot of students and they learn those mechanisms.
They do. And actually, when I teach, adult psychopathology, we talk about the DSM in its historical context, like we're talking about today. We don't say, all right, page 2 of the DSM, social phobia. Let's talk about that. We don't do that. Mm-hmm. But no, having the DSM does not preclude clinicians from doing what I do. I mean, we're doing it despite the DSM.
Mm-hmm. But then you would name the mechanism something.
I don't think you have to. There's a mechanism that maintains most of what we would call fear-based, of what the DSM would call anxiety disorders. There is a psychological mechanism, and it has to do with certain beliefs, certain cognitions, and so certain ways of thinking, and then certain behavior patterns that prevent the person from overcoming that thinking. And this is like almost 100 years old that we've understood this. So we don't need the DSM to say this is called social phobia because this mechanism is applied to social situations. And this is called a specific phobia because here the mechanism is applied to dogs or lightning storms or something like that, thunderstorms. That's not as important as understanding what the mechanism is.
I see. So mechanism first, and then and then maybe I'm just spitballing, like then specifying where the the content specificity of where it's falling into. Yeah. But being mechanism primary and content specificity secondary.
I think good clinicians ought to be doing that. I think again, I'm speaking from a kind of cognitive behavioral, which is a big umbrella, right? We include ACT in that, behavioral therapies, cognitive therapies, which again, we're talking going on 100 years of support for, we understand how these things work. B.F. Skinner, John B. Watson from the, early middle part of the 20th century, those guys got it right. Like, we don't have any better way of explaining, I'll just stick with social phobia. We don't have any better way of understanding and treating social phobia than what those guys taught us about, avoidance behavior, maintaining catastrophic thinking patterns. That's just, maybe one day we'll have better, but we don't have that now.
So you make psychometric measures, so psychological measures, and in those psychological measures, you list out symptoms or mechanisms, I guess, both in there, and you have people rate from 1 to whatever, say 5, on the severity of the symptoms, and then from that you do a statistical analysis to figure out which symptoms actually we assume are measuring the thing that we're trying to measure. So let's say depression, we might give 50 depression questions on there, and then maybe 10 of them are super good at saying that we use math to say is actually measuring depression, right? Yeah. And there's there's tons of measures that are based off of these analyses. If the DSM took more of that approach to the symptom description, so it's scientific based symptom, because you said like, well, there's some symptoms like 3 that all mean the same thing. So if they more scientifically made that list, that they were independent symptoms that didn't have too much overlapping variance or overlapping with other symptoms, if you don't know what variance is, would you be more comfortable with that? Or is that just a step in the right direction, but you still think the mechanism way is the way to go?
Well, so it tries to be more objective by having it be based on a measure that's been psychometrically, studied and developed. So I think to some extent that would be a step in the right direction, but you're still talking about, so the measures of depression, think of the Beck depression inventory, right? So I don't know it off the top of my head, but I feel sad, right? A lot. And I sleep less than normal, or I sleep more than normal. I've lost my appetite. I've lost interest in activities, things like that. Those are the symptoms. So, but we're still at sore throat disorder, right? Because we're still not looking at cause. Mm-hmm. We're still not looking at cause. And what you're getting at is another difficulty with the DSM, which is what's called reliability. And reliability refers to consistency. So if I have, I'll just go with social phobia. If I have social phobia, whatever that is, if I have that, diagnosis, and I go to 10 doctors, give me let me have a psychiatric evaluation. Tell me what I have. How likely is it that all those 10 doctors will agree that I have social phobia, right? That's the question that reliability gets at. Mm-hmm. And it turns out that the reliability of the major psychiatric diagnoses in the DSM are like around chance. The likelihood that 2 interviewees giving a diagnostic interview will agree, and I'll give you some statistics in just a second here. I'm looking for it in my notes.
And is this assuming well-trained clinicians, or is this just a random sampling?
Good question. In the study that I'm going to quote, these were trained clinicians, and they were using a diagnostic interview, like a structured
like a
diagnostic interview.
Like
the SCID, right? The structured clinical diagnostic interview. That's right. So let's take something like PTSD. The reliability of PTSD is about 0.7. That's not so bad, right? What that means is that about 70% of the time, doctors can agree, I say mental health professionals, because many are not doctors, which is fine, can agree that someone meets the criteria for PTSD. Bipolar disorder, you're getting close to 50% of the time. That's chance. Let's take a look at some others. Schizophrenia, less than 50%, somewhere between 40 and 50% of the time. Substance use disorders, we talked about that. Right? We're talking with alcohol use, we're talking more like 40% of the time. And these are statistically adjusted, right? OCD, the reliability is more like 0.3, right? So 30% of the time. Generalized anxiety disorder, 0.2% of the time.
And that's 20%.
20%?
Yeah.
I'm sorry, 0.2% is about 20. Yeah. 0.2 is what's called kappa, about 20% of the time. What does that say? I mean, and you shouldn't be surprised, because when does a worry, right? Generalized anxiety disorder is about you worry too much.
Yeah, when does it become excessive?
Who's to say you're worrying too much? Mm-hmm. Right? So again, that gets at not only the validity, like how do we know that generalized anxiety disorder is actually there?
It exists in reality.
If 2 doctors can't agree on it, how do we know that it exists in reality, right? Yeah. Logically speaking, who's right and who's wrong?
So I'll give a very concrete example, like a scale, like a scale for weight. Yeah. My scale, when I step on my scale, I get step on it 5 times in a row, and it's literally the same weight measurement every single time. So I could be very confident, or at least I could have the base of confidence that that's probably my weight. Now, the scale might be messed up and consistently telling me the wrong weight. But if we have a situation where you go on a scale and it keeps leaping 10 to 15 to 7 points, right? You don't have that base where it keeps telling you the same thing for you to even then assume what your weight, that it could accurately be telling you what your weight is. And that's how reliability works into validity. That reliability is a requirement at the base before you could even speak about validity. So what John is saying here is that if our reliability, if only 20% of people are agreeing upon, I think you said GAD?
GAD.
Yeah, GAD. If only 20% of the time people are agreeing and 80% of the time they're not, and so we're not consistently getting that weight measurement, how can we then possibly even fathom if it's real or not, if we can't even measure it correctly? And that could be a DSM problem. It could be a training problem. There's a lot of proposed reasons why that might be an issue. And I also think there's another phenomenon here of like bucket diagnoses. Like, for example, with diagnoses, we create a diagnosis when we're trying to understand a phenomenon. But in the future, they might realize that there's actually 7 different disorders that we've been putting under this one disorder. We just didn't have the savvy yet to understand what was going on, that they were separate conditions. And that happens all the time. And there's a lot of people that feel like GAD is that. The GAD is not, it's a garbage can diagnosis, that there's probably a bunch of different subsections of what maybe mechanisms, disorders, whichever way we want to talk about it. And that could also be a problem with reliability, because if your view of GAD is one of those potential, let's say 7 that might exist in the future, and mine is a different one of the 7, then we're not going to agree.
Yeah. Well said. And again, I think it's important to point out here that we are not saying that people who have, who are given these diagnoses, that they don't have problems, that they should just kind of snap out of it. We are not saying that at all. There is a problem that requires treatment, and goodness knows that in this day and age, mental health problems are definitely on the rise, and these are real problems. The question is, are they diseases in the same way that COVID is a disease? And the DSM wants to say yes. And what science and logic are saying is not so fast.
Mm-hmm. So if they're not diseases, then what are they? So very clearly they're causing significant distress, and it's a problem for people, and they are going through psych pain. So that's not a question. Yes. But if they're not diseases, then what are they?
Yeah, people have offered syndromes, maybe experiences. Let's understand what the person is experiencing, what they're thinking, what they're motivated to do, how society is playing a role, how interpersonal relationships are playing a role, how culture is playing a role. Let's understand all of that before we just say you have a disorder within you, right? I'm not sure I really know what we would call it. These are circumstances and experiences that people are going through that are terrible, that are awful, that require intervention. But they're not the same as COVID. Mm-hmm. They're not the same as diabetes. We don't have a test for them. We can't objectively see them. But they are, and that's because they're in nature, they're not there, but the person is experiencing something as a probably overlapping causes having to do with certain things within them and certain things about society as well. Things that we can change, certainly psychotherapy and medication therapy helps to change things within the person, whether it's biological factors, thinking factors, behavioral factors. But then also there's society out there too, as we've been talking about. So, I don't know. I don't know.
Yeah. Cause one thing we need to balance is being able to talk about these things with ease. So when you say I'm treating someone for OCD, I think me and you are on the same page, but maybe 30% of the time we're on the same page, but, and it's a way of talking about it. So when doing these things or making any change, you need to consider ease of communicating and people understanding what they have and what we're treating, with it actually being accurate and actually telling us something.
Yeah. And that's where I think, practically speaking, the DSM gives us something to work with, right? Because if I launched into this whole explanation of you and misinterpret, whatever, like that's not going to be that's not going to be as helpful. That's not going to look as good on social media, right? As here's the diagnosis. So again, as I said in the beginning, I don't think that the DSM is completely bad. I think there are some critical problems with it. We don't want to take it, 100%, but I do think that is a way, it gives us maybe arguably for the most part, in some cases, a quick way to relate to what someone's going through. If I say OCD, if I say Jason, I'm referring to you, someone with OCD, you have generally an idea of what we're talking about. But maybe we could switch gears and talk a little bit about what the DSM did to OCD and the anxiety disorders in the most recent iteration.
Sure. So let's take a pause here. Okay. And then we're going to have our next episode coming up on talking about the DSM and anxiety and OCD. So if you're listening, just keep on listening and you'll come on to the next episode.